Susan, 4:10. Okay, I think we're going to go ahead and get started. It is 4 o'clock on Thursday. I don't even know today. So yeah, I want to make sure people get out of here in time. Okay, I can have patience. Welcome, everybody. Thank you so much for taking time out of your day and joining us for our partnering, what are we calling ourselves now? Partnering Organization Summit. Partnering Organization Summit for HealthierHere. So you guys know this is our new name. And we'll be rolling out our logo, I'm sure, by our next meeting. You'll get to see the whole shebang. But my name is Susan McLaughlin. I'm the Executive Director of HealthierHere. And this is our second one of these summits that we will be holding monthly, really as a way to get all the provider organizations that want to engage with us and help us to transform our system locally, kind of in the same room, under the same tent, sharing the same information, kind of communicating out and hearing what is going on. So we're excited to take you through the next steps and where we're at as an organization and what's happening with the transformation planning. But before we do that, I want to introduce Elise Chayette. Elise is one of our governing board members, and she is going to say some welcoming words.
Okay, thanks, Susan.
Sorry, excuse me. So welcome, everybody. As Susan said, my name is Elise, and I've been on the King County HealthierHere governing board since its inception, and it's very, very exciting to be here now. We are at a point where we really want to engage others in the community in looking at how we can really devise a delivery system, particularly for our most vulnerable patients, that really meets patients' needs and really addresses some of the social determinants of health. Some of you have been involved in design teams prior to this point, and others are new, and we're hoping that today we'll give you enough of an overview of where we've been and where we're going, because there's a lot of work to do between now and about October, when we have more solidified plans that we need to get back to the state. But it's very exciting to be here. We actually have the potential of really looking at this delivery system in a different way. And it's very exciting to have people in the room, and as well as many people on the webinar. And we really want to make sure that today addresses your needs. So as we go through the day, if there's questions, there's going to be a small group opportunity at the end of this meeting. We want to make sure that we understand your questions and your needs so we can be as successful as possible in earning those incentive dollars to make sure that we can make this delivery system as effective as possible. So thank you, everybody, for being here. And I'm going to turn it over to, I think, back to Susan to go over the agenda, and then we'll start showing you the updates.
Thank you so much. And for those of you that don't know me and know that I'm from San Diego, I freeze when it drops below 70. So I'm having my coat on because I'm really cold, and maybe I'll get hot later. So we're going to start with some updates, and we have both some really exciting updates and some very practical updates that you all will need to know as providers that are beginning engagement with us. And then we sort of building off of our January meeting, we want to spend some time with our project portfolio and kind of ground you in an understanding of what we're going to be focusing on vis-a-vis the projects that we were selected and how HealthierHere has built out our portfolio. We're talking a little bit about the King County Medicaid population and gap to goal. This will give you a sense of what we need to do and what we need to accomplish as a region in order to keep the money flowing. Especially as we move towards paying for performance. And then we've been really working on kind of defining a framework that really starts to outline what is the role of provider organizations versus what is the role of HealthierHere and what we might be able to do to help support organizations as they transform practice. And then, as Elise mentioned, we're going to spend some time at the end today actually trying to get some information from you guys as provider organizations in terms of what you need, especially around a couple of critical areas. So with that, we're going to, ooh, geez. Ooh, no. I know. And be patient. I forgot to be patient. Okay, hold on. Sorry. I got so excited because the very first update that we have is the most exciting one, which is yesterday. We got our score for our project application that we turned in on November 16th, and we got 100%. Earned our first $23 million for the region. So super exciting. It will come to us in kind of a bumpy little way, but we'll get most of it, about 17 million, in March. And then the rest of it, about 5 million, will come in mid-May. But this allows us to really get started and to start having engagement with provider organizations and starting to move the work forward. So super exciting. A couple other things, we talked about this in January, we're starting to solidify the new organizational structure to help us move the work forward as we pivot from where we were in 2017, which was, trying to design and coming up with these great project ideas, to where we are today, which is we have to now take those great ideas and operationalize them, i.e. turn them into contracts where you guys can actually start to do practice transformation. So we are taking what was our demonstration project committee that really helped put the portfolio together, and we're evolving that into a transformation committee, which will have oversight responsibility for the entire portfolio, and we'll make sure that we're actually working towards transformation, that we are not working in siloed projects, but really knitting this together towards a set of activities that make sure we have leave behinds at the end. We had those 8 design teams. Many of you in the room probably participated on at least one of them in 2017. Now that we only have 4 specific projects from the toolkit going forward, we'll be shifting to more project-specific work groups. And those are being convened starting in March. And the way we're going to approach this is we will invite everybody who was on one of those design teams and everybody who completed our provider survey for HealthierHere and indicated that you had an interest in any of those. So like if your organization completed the provider survey and said, I want to be involved in bidirectional care and addressing the opiate crisis, you will be invited to those 2 work groups, and then you can figure out within your organization who's the right people that should attend. And those work groups will then start to dive in a little bit deeper to the project ideas that were in our portfolio and start to refine and determine like target populations and refine the evidence-based approaches, and then talk about what our next step really is, which is our kind of what are the rules, I call them the rules of engagement, sort of those things that would go into a contract. That would say, okay, you're going to do bidirectional care, here's the expectations and what you would need to do and what that would look like. And then the other thing that we kicked off this week is we hired a consultant firm, Point B. Some of you may be familiar with them. They're a local firm that is going to help us crack this HIE-HIT nut, our Domain 1 infrastructure strategy, really around well, it'll start with a kind of a landscape, what's out there, who's using what, especially for care coordination, how is information being shared across provider organizations, is anybody working off of a shared care plan today, if so, how are they doing that, and then help us collectively to come up with an effective solution that we can implement and invest in that will take us further along that I don't think we'll have like the total answer that's going to fix everything, but at least be further along with developing shared care planning, getting information moving across organizations, and connecting our community-based organizations to the healthcare delivery system. Yes?
Quick question for you on the project workers. Some of the other pieces that Providence is involved in, what we're hearing is by project, they are asking partnering organizations to submit proposals for work that they would like to do within that project at their own organization, and not necessarily requiring every participating provider to be doing the same project. Is that where King County is going, or have we decided yet?
So we don't expect every organization to be doing the same projects at all. We are not going to do like any kind of RFP process or have people submit ideas. We are going to, the activities will be framed, but we will have organizations, we haven't figured out this. I mean, the idea is that as an organization, you need to transform the way you're doing business anyway, right? And we're going to get into that. And so the first step is figuring out where are you in terms of like sort of the projects and what we're going to be focusing on those projects, and where do you want to be, and then what's your change plan to get there. And then you'll see when I kind of get to the framework that how the ACH may or may not be able to help you by providing some catalyzing resources to do that. I think it will vary by provider and provider type, how they engage with us and how they're involved in the different projects. So we'll go through that. So asking that question again as we get toward the end and see if it becomes clear or if it's still like clear as mud. Yeah. I always have to. Okay. So I'm going to turn it over to Twee, who is our Chief Financial Officer. This is important information to be aware of and to pay attention to timelines about. This is the registering in the financial executor, which is the way providers will get paid.
Thank you, Susan. All right, so this is an update following from last month's summit. And basically just want to let you guys know that what we're doing is on a monthly basis, we work with a consultant with PCG, who's our financial executor for the state of Washington. And it's about the 15th of each month that we do a batch upload of all providers that register through the provider survey, and then transmit that to the financial executor, who then, what they do is they perform the match, and this is very mechanical, of the employee, the EIN number, the employee identification number against the organization name. And a positive match is where those two items match, and it match with the IRS database, and so you're good to go. If that's the case, then you'll get be contacted by the financial executor, the PCG, to actually enter more information into the system. If there's a negative match where those items do not match between the EIN number and your organization, and I found some that are either the EIN number was short by 1 digit, or the organization name was not exactly what was registered. If that's the case, they actually contact me, and then I'll reach out to you guys based on the contact that was listed in the provider survey, and then we'll straighten that out. Once I get the corrected information, I'll resubmit it, and then if it matches, then you'll get contacted by the financial executor. Also want to let you know that in March, sometime in March, I think it's probably going to be more mid to late March, the PCG or the financial executive will be putting together a training for all the providers so that you can know how to maneuver within the portal. And then lastly, if you haven't done so already, there is a link, and I think this is also available online, that you can access and go in there and register yourself as a provider. Towards the end of this meeting, I'm going to be in the back of the list of all the providers I have to date, which is about 85-ish. And so if you want to check and know whether you're on the list or not, should you go back and should you go in to register, just let me know, and I'll walk you through it.
Can I say one thing?
Just so I want to make explicitly clear, if your name is on that list, if you're one of those 89 providers, unless there's a faulty match, you'll get an email from PCG probably sometime early next week that will lead you through the process of finishing your organization responsibility for registering within the financial executor. So we are in the process now. So I just want to make sure people understand that if your name is on the list and you don't hear from Twee saying, sorry, you're short a number or something, you should get an email from PCG. If you don't, let us know.
Thanks, Susan. And they'll be asking for banking information so that when we make payment, we know where it goes to, etc. So the next part that people are always asking about is where we have the allocation of money and when will it go out and other contracting questions. So for that, just want to let you know we are, now that we know that we got 100% earned incentive for our projects, we're in the process of working on the allocation distribution to get approved. And then parallel to that, we're also looking at agreements, and all of this I'm hoping that we'll get it all figured out by the end of May or so. And what we'll be using, this is really, is a partner provider agreement that's already in the financial executive portal. It's a statewide agreement, and we cannot want to make sure people understand, We cannot make any amendments to that agreement. That agreement is as is. But it needs to be, we'll get that, what they refer to as a click agreement, because you'll go on there and you click through it and you sign that you agree to it. What we'll do for 2018 is that we're looking at using an addendum, which refers back to that partner agreement as umbrella agreement. And then in the 2018 addendum, we'll address what the deliverables or what expectations for providers are from HealthierHere. For 2019 and beyond, what we'll do is we'll have another addendum to address the work that's going to need to be done for 2019 and beyond as a separate document. But again, it will refer back to the partner agreement because that agreement allows us to make distribution payments to providers. Any questions? Thank you.
Thank you, Shui. So this is a way for us to not have to do like big clunky contracts with everybody. We can just, add these addendum on. I will say we are going to send out, so we have this partnering provider agreement. I know many of you are in organizations where you have legal departments, and that this might take a while for your legal department to review so that you actually can click it. So we're going to send that out to everybody who's registered for this and on the list, so you can take a look at it and start working it through the process, so that way when you get to the point where you're registering, it's good to go. Okay, so let's spend some time on our transformation portfolio. So if you were in our January meeting, you saw this. This is what the HealthierHere project portfolio looks like. At the top are the 4 projects that are defined in the Healthier Washington Toolkit: integrated whole person care, bidirectional integration, the opioid use disorder, prevention and treatment, chronic disease, prevention and control, and transitional care. And as, of course, you've probably heard many of us say many times, we will be threading in aspects of the other project into our overall system transformation, but these are the projects that we are accountable to. And then underlying that project portfolio are kind of the foundation of the transformation work, which is really developing a rationalized community-based care coordination, addressing the social determinants of health and really linking in our community-based organizations to the healthcare delivery system, and addressing equity and reducing disparities in our region. So these are the things that we will be working on over the next 4 years. And these are the project metrics that we will be accountable to as a result of selecting that project portfolio. So the kind of bluish purple P for pay for performance measures are prescribed in the toolkit and attached to the projects we selected. You can see, and you might remember that part of the strategy was to have as much overlap as possible so that all the work that we're doing, we're driving towards these metrics in multiple ways. The other thing that we wanted to represent is that some of these metrics are also things that you as provider organizations are being held accountable to through your managed care organization contracts, especially through value-based payment that you might have with them. And so, again, our job is to help you get where you already are trying to go and to help move the needle on metrics that we are all, from the state to the MCOs to provider organizations, being held accountable to. Not do something different, not set up projects over here that are not part of the day-to-day work, but really look at system transformation. Another thing that we have to take into consideration in this next phase is where we're going to start and what target populations we're going to focus on. And so the design teams have done a lot of thinking and work and really digging in with our King County evaluation partners into our regional health needs data and looking at where the greatest need is. Just want to remind people and call attention to this balancing act that we have to do between meeting our performance targets, which means touching as many Medicaid lives as we possibly can in our transformation work, and actually addressing issues of equity and social justice and where the greatest disparities exist in our region. And that if we went straight after this, we're probably not going to move the needle. And if we just focused on here, we probably aren't going to reduce our disparities. And so our work needs to balance those two approaches while at the same time taking into consideration the needs of our Medicaid members, provider capacity and willingness, and I would say add readiness to do this work, and then the specific strategies that the toolkits have laid out. We're going to talk today about the specific projects, the 4 projects that we selected, and this might be the last time you hear me talk about projects, because those of you that know me know that this is not about doing 4 separate projects. This is not grant money. We are not going to do projects and then when the money goes away, the projects go away. We are going to transform the system. And from a statewide perspective and from our regional values and what we want to do, this is what it's really all about. We are going to move how we pay for care and transition to value-based care, where we are making sure that people have access to evidence-based or best practices approaches, and that we have a value-based payment system instead of fee-for-service. We are going to make sure that we are taking a population health management approach to the work and to care. We're going to make sure that people have access to integrated, team-based, whole-person care, putting the head and the body and the teeth all back in the right place and making sure people's entire needs are met. And then we're going to link social services or the social determinants of health tighter into the healthcare delivery system, because we know that most of what drives a person's overall health and wellness happens outside of a clinic. So that is what this is really about. And so even though I'm going to go into details about the projects because that's important, you've got to think about it from this lens. And you've got to think about, as an organization today, what do you have going on in these kind of 4 arenas? Do you use evidence-based practices in all the care that you deliver? Do you have any value-based payment arrangements right now that you're in? Do you have systems in place and technology tools to do population health management? Do you think about the population that you serve from that perspective? Who are your community-based organization partners? Do you have them today? If not, who might they be? Okay. So bidirectional integration, physical behavioral health integration, is one of the required projects that all of the ACHs around the state need to do. The objectives of this project are to improve access to behavioral health care from the primary care setting and improve access to physical health care for people who are being seen in and we'll do this through increased screening mechanisms and identification and then linkage to treatment. Also to improve care coordination among medical and behavioral health providers. Not everybody's going to live under the same roof, but we need to talk to each other, hence the concept of a shared care plan, which we'll talk about. And then aligning new bidirectional integration with our successful community efforts. This is really important. We've got a lot going on in the King County region, so really building off of that. And then adding in this community-based organization and addressing the social determinants of health. So I stole this, and so I'll just own that slide. I modified it a little bit, but from Julie Lindberg, who works for Molina Healthcare, because I think it's a really good depiction. So find yourself over here. Are you a primary care organization that sees kind of episodic behavioral health conditions that are common in your clinics, and you might come in with some mild depression or an anxiety disorder? Are you primary care, but you manage kind of individuals with chronic behavioral health conditions, or are you a specialty behavioral health organization? Because that kind of tells you what you need to be thinking about vis-a-vis what the toolkit tells us. And so these are the approaches that are prescribed in the toolkit. And so the expectation would be that you're implementing the recommendations from the BREE Collaborative, or doing the collaborative care model, or looking at enhanced collaboration aspects as they're outlined in the Substance Abuse and Mental Health Services Administration integration guidelines. Yes, Brad, you're raising.
Yeah, is there before I ask a question, is there another slide?
There's one more, yeah. You want to wait? Okay. For those of you on the webinar, Brad is going to wait. He was going to ask a question, but he's going to wait. So the transformation money would go to help organizations then in planning to implement these best practices, training of staff, additional workforce that might be needed, and achievement of outcomes. So for HealthierHere, what we'll be focusing on through the course and through the defining of implementation for this project will be really helping to strengthen providers' ability and capacity to provide client-centered whole person care through training. So we do workforce training, provide resources for that, technology, client registries to do population health management, those things, and building the workforce capacity. Building on existing efforts, so that will be really important. We're not going to force a model down anybody's throat. So again, part of the next step for this implementation planning phase is doing a current state assessment and a readiness assessment of where providers are at. So if you're not thinking about that or doing that already yourselves, you should be. And then thinking about where you want to go. Making sure that we're addressing unmet need in treating identified mental health and substance use disorders through screening and access to care. And then we have a very unique role in helping to support the transition to fully integrated managed care. And this is the payment transition that's happening in King County. As a mid-adopter, this move will happen in January of 2019. And so we have some additional incentive money that is available to help support primarily the behavioral health providers transition their business model to move into this new environment. Do you guys still ask your question, Brad?
Yeah, can you go back to the slide before?
Yes.
So, I think this slide is really good thinking about it from a semi-population health perspective coming in through the primary care door, but I don't know that it necessarily addresses when you have people that are already involved in the behavioral health system and the primary care needs that might come up where there's interest in getting some level of primary care through behavioral health provider.
Yeah, so I think that that's an individual organization kind of business model decision. And when we get to kind of the framework at the end, I'll talk a little bit more about that. But again, from HealthierHere, from an ACH perspective, we're providing resources to help providers get to where they want to be along the continuum and really doing, moving towards these 4 things. And every provider is going to be in a different place. And so we'll have different needs, and therefore we'll need different resources for us. And some providers, so if behavioral health organizations might decide to create a partnership with a community health center and then to have a process for easy referring back and forth and making sure primary care needs are met. Other community behavioral health organizations might decide to hire their own primary care staff. And so there's many ways to do this, and we want to make sure that providers are met where they're at. Okay, so transitional care is our next project. And again, in terms of the project objective as it's defined in the toolkit, it's to improve transitional care services to reduce avoidable hospitalizations and make sure that beneficiaries are getting the right care in the right place. And there's 3 target populations that are identified in the toolkit. So individuals transitioning from inpatient hospital settings, transitioning from inpatient psychiatric settings and facilities, and individuals transitioning from the jail. So we will be focusing on all 3 of those populations in some shape or form. And where the focus will be for this is, again, building capacity in providers, introducing, if you're not already doing, evidence-based approaches to transitional care, the APIC model, the Coleman model, the Peer Bridger model, and across the 3 target populations. Investing in transitional care approaches, improving quality, and then building these strong linkages to community-based organizations. Again, technology investment, workforce capacity, with the goal of decreasing readmissions and incarcerations. Ultimately, we hope that will result in cost savings. And then increasing access to multidisciplinary care teams and community-based care coordination upon transition. So bringing people from an institutional setting back into the community, into a multidisciplinary care team that can then hold them and help them maintain stability in the community. Addressing the opioid crisis, the objective here is to support the achievement of the state's goals to reduce opioid-related morbidity and mortality through strategies that include targeted prevention, treatment, and recovery supports. So this one is most straightforward, but also the most complicated because it has multiple steps in it. We will be working this from all angles. For those of you that are kind of in this space, you know there's a lot going on in our state right now around addressing opioid use disorders, and we have the King County Opiate Task Force as well that has done a tremendous amount of work. So we will be complementing and aligning with them and adding additional resources to either help accelerate or scale some of the work that's happening in these 4 areas. So the first one is really about, sorry guys, I'll get it by the end, is about prescribing practices. So this is a biggie there's some statewide guidelines and some guidelines that the Free Collaborative just put out around opioid prescribing practices. So we're wanting to make sure that those physicians and other prescribers that are actually prescribing opioids, including dentists, that they are following the guidelines and that they have access to and are using the prescription monitoring program. And there's a desire at the state level to actually have that integrate with electronic health records. And so that's a place where, again, ACHs can come in and help to support getting that integrated into electronic health records to spread that. We'll also be focusing on expansion of low-barrier access to medication-assisted treatment. It's really about buprenorphine prescribing primarily. And so we want to expand capacity of prescribers who are waivered or certified to prescribe buprenorphine, but also where, like, so for example, training emergency department doctors to do induction in the ED with a mechanism building under the treatment, a mechanism then to transition that person to a treatment team to hold them in the community. So you can get somebody started when they come in on an OD or on opiates, get them induced on buprenorphine and get them transitioned into treatment seamlessly. And then, again, continuing to build that treatment capacity, making sure recovery supports are wrapped around people that are individuals in treatment. And then the last thing is distribution of naloxone kits to prevent overdose. So there's a huge effort on this already going on in King County because of the opiate task force. And again, we'll add resources as needed to expand capacity or scale that. And then the last project is chronic disease prevention and control. And the project objective here is to integrate health system and community approaches to improve chronic disease management and control. And HealthierHere is going to focus really in 2 areas, at least to begin with: children and adults with chronic respiratory diseases, including asthma, and then adults with chronic cardiovascular disease, including diabetes. So our focus will be the use of registries to identify and track the 2 populations, and then provide an evidence-based approach around educating, providing care, following, and tracking based on risk and family need for those individuals with chronic conditions. And then redefining the integrated care teams to include social workers and pharmacists and dietitians and community health workers and kind of non-traditional workforces that aren't part of a care team but need to be in order to effectively meet the needs of individuals with chronic disease. And this is not it's not a required project per se, but as you saw in the slide, it's fundamental to our overall project portfolio and success, and that's community-based care coordination and addressing the social determinants of health. So we will be working to rationalize and build off of the current care coordination activities and infrastructure. So we have a ton of care coordination going on in King County. In all different places, from managed care organizations, which do their own care coordination, to provider organizations. And so we want to try to understand what is really happening, try to make sure that we can get one peer coordinator to one person instead of some people have 5 and some people can't get 1. We will invest in mechanisms for shared care planning. We're going to talk about that more today. Support strong two-way partnerships between our community-based organizations and the social services with the healthcare delivery system. And part of our work ahead is to kind of define what does that mean and what will that look like, and working with our community-based organizations to figure that out. Make sure then with that strong partnership that there's two-way referral and tracking mechanisms in place. So if you're a primary care doc and you have a patient in front of you that needs housing and you refer them to a community health worker to help them get housing, you get information back to know what's going on, that that's being worked and so forth. And then continuing to support the sharing of information across provider types and looking at what infrastructure is needed to do that. Okay, so again, this is our entire project portfolio. It encompasses those 4 projects, as well as community-based care coordination, addressing the social determinants of health, with an eye towards reducing disparities and dealing with equity. So thinking about this from an organizational perspective, you need to be thinking about what within sort of everything that I just described and those focuses am I already doing, or does our organization want to be moving to, and then how might I engage with the ACH to support that. Okay, and then this is just a graphic that tries to then sort of move from that project-based approach to what I just talked about, which is tying everything together. And so and if you remember from the January forum, I shared the vision of HealthierHere, which is really moving from what we have today, which is a crisis-oriented response to health and social concerns. We spend a lot of time, hospital, ED, jail, EMS, fire, police, a lot of time and money goes here. And what we want to do is to shift that to a prevention and management of chronic health and social concerns, and knit together our specialty care and our primary care and our behavioral health in a kind of rationalized care coordination, coordinated way, and look for those transition opportunities and diversion opportunities to get people back to here. Make sense? Okay. I wanted to share this slide with you too, because as an organization who's going to engage with us and who also is trying to think about how am I going to do those 4 things that this is really about, most explicitly the move from fee-for-service to value-based payment. These are the kinds of capabilities that you need to have as an organization and need to be thinking about. So your job is to look at these and say, do I have this, or does this exist in my organization or not, and what is it going to take to get me there? And this is kind of a continuum along the continuum of how much risk your organization is going to take in value-based payment arrangements. So they become more important the further along that continuum of VBP contracting you go, but they're all important. So governance and organization is really about does the leadership understand the vision, and are they on board? What kinds of workforce development is needed? Do we have effective practice management systems in place, revenue cycle management, performance management, and so forth? And then there's the provider. This is like direct service provider engagement, because they're going to have a role, because a big part of VBP is being held accountable to quality metrics. And so what, as a provider who's seeing patients every day, what is my role in making sure that those metrics are being met? Care coordination and management. Is there a single point of assessment? What kind of care coordination services exist? Do we have comprehensive care plans as an organization? What is our patient engagement like, and so forth? And then the technology and analytics. So do you have a population health management tool or system in place that really allows you to look at populations of health? And then again, who are my community-based partners? Do I have partnerships? How do I make a referral to housing if somebody needs it, or to employment, and so forth? So again, another tool for you as provider organizations as you think about how you're going to transform and what you need to do to evaluate yourself along this continuum. And then I showed this slide at the January forum as well for those of you that were there. I just love it because I think it's the best representation of how this is all really supposed to work at the end of the day. This is the district incentive funding. The incentives come into our delivery system and we make investments in different kinds of, whether it be workforce capacity, IT infrastructure, training and evidence-based practices, that hopefully in doing that is going to result in higher value care. We're going to serve people better and we're going to get them what they need. And then in VBP arrangements, there would be financial rewards for providers for achieving that quality, high value care. And then it becomes kind of a sustainable cycle. So the more value you get, the more you can invest in those kinds of high value activities, and then you continue to get high value care and so forth. So at the end of the day, that's kind of what it's supposed to look like. This is the state's kind of how they talk about transformation and moving the system. And so, again, having this from our current system that's fragmented and disjointed to moving to one where there's integrated whole person care, coordinated care, activated clients, and so forth. And I'm supposed to actually share a client story, and I think I left it somewhere, so I'm going to skip that part of how to share, but I'll find it and share it later. Okay, I'm going to turn it over to Marguerite Rowe from Public Health Seattle King County, who is going to talk to us a little bit about Medicaid members in our region and what our gap to goal looks like.
Thanks, folks. And my understanding is that we'll be sending this out, or you'll also be able to get the slides online. So not to worry, the slides are coming. So just a couple of things for folks to maybe recall is that as part of our plan, we needed to do a regional needs inventory. And that is, if you in fact download the plan, if you've read that, I don't know how many pages, it was 160 something pages. In there is a draft of the regional health needs inventory. And in addition, we have on the website data resources for you to explore. And so what I'm going to talk about a little bit is just a little bit of the data that we have captured there, but we would encourage you to go and explore. There's a lot of data that's available to you through data visualizations and also more summary presentations. And I'm going to have somebody who's got it clear. Thank you. So here's what we know so far. Our latest numbers about Medicaid members. There's about 1.6 million Medicaid lives in Washington State. About 22% of those are King County residents. You'll note that about 40% are children, and then of the remainder 60%, 60% of the adult lives, 60% of adult lives are covered under the Medicaid expansion, otherwise known as sort of the newly eligible. Of those, you know, when we think about, you know, what are the characteristics of the Medicaid population, they tend to be younger, they tend also to be older. There are about 50,000 individuals who are dual. They are more likely to be female. They are more likely to be a person of color, speak English less well, live in a linguistically isolated household, receive food assistance benefits, rent a home as opposed to owning a home, experiencing a high housing cost burden, unemployed or not in the labor force, or have low educational attainment, or to report a disability or difficulty such as hearing, vision, independent living, or so forth. Importantly, just to be, you know, as we think about this from a population health lens, these are, the Medicaid population have fewer material resources available, or may face additional barriers to care as we think through what a transformed system is and from an equity perspective. Next. So where do Medicaid members live? And so in our analysis, we looked at the zip codes and where we have higher proportions by zip code of Medicaid lives, and you'll see particularly along sort of that I-5 corridor and particularly as we go into South King County. You'll see that's where a greater proportion of Medicaid lives are. The darker blue represents higher proportions versus the lighter blue. That is not to say that we don't have individuals across the entire region. Next. So I'm going to tell you what the point of this slide is, and then we're going to then we'll sort of go into the details. So this is data that was actually provided to us from the Department of Social and Human Services resources, research design and analysis unit. And what's been important for Healthier Here is really about maintaining an equity lens throughout our conversations. And this really talks about the disproportionality that exists even within Medicaid lives. So if you were to just focus on the left-hand side of the slide, and for those of you on the phone, really we're looking, for instance, where at the box that has like by 6 by 4, where you see any mental health need going down to co-occurring mental illness. So if we were to slightly change this, what you would see on the left-hand side as we go down is elevated risk for a behavioral health need. And the way to look at this is also that what we're looking at is from an equity standpoint, the green being closest, where it is where the disproportionality is less, into the red where there is greater disproportionality. So let me walk you through one example here. So for those with 3 or more ED visits per year, there is a 2.2 times greater risk of having a mental health need compared to those who have fewer than 3 or more ED visits per year. And so as we look at those with 3 or more ED visits per year, there is a much greater risk of having a co-occurring mental illness or drug use. And so from an equity perspective, you could see that in these areas in red, this may be one of those areas where the ACH could have an impact. So, questions, comments before I move on? I see faces that are digesting.
Walk us through another example.
Sure. Let's look at the green under arrest. So what we're comparing is among those who have an arrest and those who do not have an arrest. So among those who have an arrest, there is a 1.4 times greater need, or they have an identified mental health need compared to those who have not been arrested. That's how we look at these boxes on the left.
So I'm just guessing, like if you look at homelessness and mental health need 1.5 times, and you look at persistent ratio,
Ethnic disparities also exist, homelessness 1.7. So you're saying that the general population of homelessness has 1.5 times a mental health need, but if you're Black, you actually have 1.7, and if you're Medicaid,
so ignore the other side of the slide for a second. Now I will get to that. So let me go on to what this is saying. So on this side, on the right side where we've got Black Medicaid members and American Indian Medicaid members, what this is a measure of is of relative risk. So for instance, in homeless individuals are 1.7 times more likely to be Black. So let's go to the American Indian Medicaid members. So Medicaid members who do not receive a follow-up after ED visits for alcohol or drug dependence within 7 or 30 days are 1.8 times more likely to be American Indian. So here on the right-hand side, the denominator is going to be either homelessness, for instance, or no follow-up. So lots of folks that are digesting. Let me tell you again what the bigger point is, which is that Medicaid members there are some Medicaid members who experience greater disproportionality. And that's from an equity lens, that is where the opportunity is for the ACH to make a huge difference, right? So we may want to say, from an equity perspective, we want to make sure that we focus on these areas that are in the red to the yellow. That may be a choice that the ACH wants to focus on. I do not have Eli Kern's magic.
Yeah.
So can we go to the next slide? So on this next slide, for folks to remember that for the ACH, for all ACHs, in terms of how we earn the dollars, in the beginning years we are paying. There are measures that we need to meet that are paying for reporting, and then as we go into the years further out, it's around paying for performance. Another thing for you to remember is that when we look at, even for the pay for performance data, what we're being measured at is at the regional level overall. So for us, all of King County, not by individual providers. That's important to remember. And so what we wanted to do is to have a sense of, well, what does that mean in terms of what kind of performance would we as a whole in King County be looking at? There are two ways that that the state looks at measures. One is gap to goal, and the other one is improvement over self. And so for gap to goal measures are sort of those indicators where we have a known benchmarks. For instance, looking at NCQA or HEDIS measures and looking at the 90th percentile. And so gap to goal measures, the initial target is equal to the current King County rate plus 10% of the difference between the King County rate and the 90th percentile. So when we looked at these measures and looked at the rate, we did the calculation to be able to understand how many more additional individuals, for instance, would we need to make sure that we reach in, say, the first year where we are underpaid for performance. So for the very top measure, mental health treatment penetration, using a broad definition and of looking at adults, we would need to make sure that an additional 636 adults are being treated over baseline. For diabetes care, we would be looking striving to assure that we had an additional 428 adults in King County who would receive an eye exam. All right. Yes, Howard.
So that's the first year when we're in the paper reporting.
Those are the.
Not for paper reporting. This is paper performance.
So 3 years from now, roughly?
Well, not 3 years from now, because we are already in year 2.
Okay.
So year 3.
Okay. And if I recall correctly, you had 350,000 enrollees in King County.
Mm-hmm.
So those do not seem like a huge stretch, just looking at those numbers. Is that your feeling about this, or am I misreading?
My feeling that is it doesn't look like it's a huge stretch, but the examples from other district states is that in fact that these are actually harder targets to reach than we thought. And part of it, remember, is that we also are needing to reach more complex patients. And in our goal to reach more complex patients, it makes it harder. Eye exams are a great one where part of the challenge is really around provider capacity and not having enough specialty care to address the eye exams. So there are many reasons behind any one of these measures why it might be either easier or harder to reach.
So for the child access to primary care metric, how is access defined, do you know?
I believe it is a well-child visit, but I would have to double check that. All right, so the last thing to know is that, where we have data, we've tried to do an estimate. The healthcare authority will actually be generating those actual targets for us. And so we don't, but we think this is a good estimate to look at. Each one of the projects that Susan went over, the bidirectional, the transitional care, the chronic disease, and the opioid, each have a set of select measures that are associated with that. And then if you could go to the next slide. So one of the one measures that crosses all of the 4 projects is around ED visits. And when we look at ED visits for those, and this is, there are a couple versions. The one that is on the website, you'll see it's just for adults 18 to 64, but this one is currently all adults. And you would see that an estimate here is that we would need to have 3,500 fewer visits by 2019. So, that would take some work. That would be by the end of 2019. Are there questions?
I mean, a lot of this is really, I can't work that we did.
You have to speak louder.
Okay, thank you. So, some of the work we did with bidirectional care workers is really about designing interventions that get us our message, right? I mean, I imagine that's going to be part of the process to design for, just think about provider involvement.
No, it's Susan answering the question. Sorry, what was the question exactly? Okay, yes.
The question was, we have these metrics, and we have to move these metrics because that's what we're accountable to, right?
Right, to earn funding.
To earn funding, right? And so a lot of the work that's going to have to be done in the upcoming work groups, of the 4 work groups or that structure, is about designing metrics to help us reach these goals.
Designing interventions.
I'm sorry.
Yes, yes,
That's your question.
I know. No, that's absolutely right, which is why we can't do 4 separate projects. We need to, because the people that are going to the ED span all of those things. There are people with severe chronic mental illness, there are people with uncontrolled asthma that are living in poor quality housing. There are individuals with opiate use disorders. And so we need to create a system so that when they land there, regardless of why they land there, that they're getting connected back into a treatment team that can meet their holistic needs. I don't know. No. Say it and I'll repeat the question.
So, I think part of the work group, I know too, and I'm looking at this from an NCQA perspective, and then kind of a gap goal analysis. But we work with providers and also MCO partners who are engaged in closing gaps anyway. It's an opportunity for us to look at what are all the programs that we have going now to close those gaps with our providers, and then leveraging those to, get everybody organized it up a little bit to, you know, kind of address the actual performance measures. So I think that there's a lot of work that's been done that can be done differently or better. And then there's new work that we continue to do.
Yeah, so that was a lot more than a simple question to repeat, but I will try to summarize, and you can correct me if I'm wrong. This is for the people on the webinar who can't hear you, not for people in the room. But I think the point is that these metrics are metrics that many of us are being held accountable to in one way or another, that there's efforts going on to move them, and the opportunity here really is to collectively design together and build off of what we're already doing to drive toward improving the metrics and making the system function better. Probably missed a couple other points there, but okay, thank you. Other questions? Do we have more data? No. Doesn't? Okay. So I'm going to come back over here, and then I'm going to go through this next bit about that will hopefully start to also define this sort of the role of the HealthierHere versus provider organizations. And I will start by saying this came out of having several meetings and so many people going, what do you mean by provider? And physicians coming directly into the room and trying to figure out like who are we engaging with? Because we as an organization can't talk to every physician or clinician or direct service provider who's doing services, but they're actually the ones that have to practice differently. And so how do we make that all work? So here's where we're at. This is, I'm going to walk through this. So along the left-hand side here, we have kind of the different levels of engagement. We have what's going on at the system level in terms of Medicaid transformation, what needs to happen or is going on at provider organizations, what individual providers, these are your direct service providers, and what are the expectations there, and then the individual Medicaid beneficiaries. So I'm going to start with the transformation activities at the system level. This is irregardless of ACHs and Medicaid waiver, the state is changing its financing. It is happening, whether you like it or not, it's happening as we speak, both in terms of moving to fully integrated managed care, so moving all the Medicaid money for physical health and behavioral health into single managed care contracts, and they're moving from fee-for-service payment to value-based payment. So whether you like it or not, that's happening. They are moving towards, driving towards integrated whole person care. Provider networks are shifting right now. There is a lot, whether it be mergers, partnerships, acquisitions, you know, trying to kind of figure out, everybody's trying to position themselves. We have community and consumer voice, really trying to elevate those that are most impacted and have them drive the system change. And that's a value that you hear about statewide, and there's a lot of mobilization around that. And then we have this desire to obtain transformational results, really do business differently, create better health outcomes, and so forth. And so all of this is going on. As we think about moving towards transformation, system transformation, at the provider organization level, you guys as agencies have several responsibilities. You've got to figure out how to manage risk under VBP arrangements, right? And how are you going to do that? What's your business plan? What's your financial model? What is your IT HIE situation? Do you have an electronic health record? Within that, can you do population health management? Do you have a client registry? Those kinds of things. What are the standards and quality improvement strategies that you have within your organization? Are people getting best practice care when they come in to see someone? Who are your partners? There's a lot of new partnerships going on, and really if you don't have, if you're a primary care clinic, for example, and you don't have a behavioral health partner or have it in-house, or you don't know where your housing partner is, you need to start figuring that out. You've got, I don't know, varying size, but clinicians, direct providers, whether it's physicians, social workers, people doing the work that you need to support. And then we need to make sure that we're reinforcing the culturally and linguistically appropriate services standards, the class standards, if we're really going to address issues of equity and health disparities. So all of these things need to be happening at the organizational level and are the responsibility of the organization. At the individual provider level, in this role of transformation, it's about health teams. So are you set up to pull together multidisciplinary health teams? What does that look like? How does that impact workflow? Who needs to be on those teams? How do we deliver whole person care? What happens when somebody comes through my door? Do I screen them for mental health and substance use disorder? Do I screen them for pregnancy intention? Like, what does that look like? How about, do I ask about oral health if they see a dentist? And then are my services culturally and linguistically appropriate? Do I have staff that matches the clients that are coming in the door? Do I have access to language interpreters? And then at the individual Medicaid beneficiary level, it's, it's about the quadruple aim, improving health outcomes, having a better experience, and then making sure that the care that's being delivered is culturally and linguistically relevant as well. And that's our, again, trying to make sure that we maintain that equity focus. So if all that is going on, then what do we need the ACHs for? And what can we do, or what is our role, really? So, we're going to get, we are getting this money. We're going to get $23 million very soon. And so it's not going to pay for all this stuff, right? It's not going to pay for all this system transformation, all the things that you need to do as an organization. But it can help catalyze some of it, or it can help, subsidize some of it. It can help support making that transition from fee-for-service to value-based payment arrangements from a business model perspective. So our role is to do just that, support the move to value-based payment by convening partners, providing technical assistance, training, and resources. The state is making those available, and it will be our job to let you guys know as provider organizations that they are available, get you what you need to help you think about how do I make that transition, what's my business plan. We need to monitor system performance. We obviously need to move the needle on those metrics to keep money coming into our system, but we also want to make sure care is improving. I talked about supporting the transition to fully integrated managed care. We want to support and invest in a robust system of care coordination. And this is a big fundamental piece. We have a lot of it going on, but it's pretty fragmented and disconnected. At the provider organization level, this is where we'll really be investing a lot of our resources. We'll incentivize provider organizations to participate with us and do the work under the projects. We will make what's called Domain 1 investments. This is infrastructure investments. So do you need an electronic health record? Do we need to build a platform for shared care planning? Do you need provider registry or population health management tools? We can help, again, we can't pay for the entire thing, but we can help provide resources. Building workforce capacity. Building this bridge between social services and community-based, social service or community-based organizations to the health system. What does that look like? And then for those smaller providers, again, with this transition to VBP, potentially doing some revenue loss arrangements to help you get over that hump to the new payment structure. At the actual practice level, we will sponsor system-wide trainings on best practices and evidence-based approaches. We could subsidize positions within organizations, either to be champions within an organization to support practice transformation, or it might be workforce. It might be paying for a community health worker to do some of this work to demonstrate that value that then gets a better outcome that drives quality and payment structure. So those are some examples of the role of the ACH and the things that we can do to help support you guys as provider organizations in transforming how you deliver care. The other comment I'll make is that the ACHs, we are coming in at this level. Okay, so what we will be going to the provider organization at the highest level and saying, what is your change plan and what do you need and how can we support you getting there? And then it's really the provider organization's role is to bring along individual providers and make sure that there's policies and protocols and other things that are developed to support practice changing on the ground. We can help, broker or pay for some of that stuff, but it would be in the direction of the provider organization. Yes?
How much of the work, especially around the Domain 1 investment, are we working with other ACHs on? we're not implementing a bunch of different solutions across all 90.
Yeah, thank you for that question. So the question was how much of the work, especially around the domain one investments, are we working with other ACHs so that we can align strategies and or is the healthcare working on so that we have a statewide approach? And I will say the short answer is as much as we can, and the longer answer is we have a lot of work to do to kind of figure out what that looks like. But all my ACHs meet weekly, and we really stepped up. Actually, we're going to start longer meetings now that we have our project portfolios and we know what we're all doing to try and figure out what are our needs in these domain one and where can we leverage each other or streamline or come to agreement on investing in it if it's a particular product or tool or something, so we don't do things 9 different ways. At the same time, we are also having conversations with the healthcare authority where it makes more sense for it to be a solution that happens at the statewide and at the state level or a decision that's made that's going to be a statewide solution, and then we all kind of jointly invest in it. So we're working really hard on that, but I will say, excuse me, the dynamics and the politics and all of that at every region vary significantly, and there's a lot of reasons why a region may or may not want to get on board with something that most of the other regions want to do, and so we have to get over that hurdle. I think the other thing that's driving that puts us at risk of doing things 9 different ways is the time pressure. And so because it takes a long time to reach consensus on both within your region and then across 9 ACHs on what the approach is going to be, and we don't have a lot of time to do the implementation planning, there's pressure to just then find my own solution and move because I can't wait for everybody else to come along. So we're trying to navigate around that and do the best we can. Other questions? Okay, so I just wanted to remind everybody, this is the HealthierHere Governing Board went through a process last year and said, okay, we've got 5 years and, an amount of money. We can't do everything. We're not going to fix the whole system. If we had to prioritize and just really focus in our thinking and our investments in a few areas, what would they be? And we call those our 4 leave behinds. And this is what they are. It's really this HIT interconnected system that allows information to flow across providers working off of shared care plans, allowing for that coordination of care and communication to happen. It's access to multidisciplinary, culturally competent care teams, inclusive of social services. So that concept of a health home or a patient-centered medical home for everybody. So that regardless of what that person's needs are, you're able to kind of pull in a team member who can help meet that need. And then the last one is meaningful community consumer involvement and voice in driving the system. So people that are most impacted by the system transformation are really having a strong voice in how things are moving forward. So we are working on all 3 of these things. Our portfolios, we get into implementation and operationalizing those projects. These leave behinds will be taken into consideration, and it will be about how can we make this a way of practice and make sure the infrastructure for these things exist in our region. These are our 2018 activities and deliverables. I think you saw this in January if you were here. So the first 4 are due at the end of June, and then our final implementation plan is due in October. So first and foremost is the current state assessment. So this is what I was mentioning earlier. We need to figure out who's ready for what, when, kind of thing. So what technologies exist within your organization, who's ready to move, who needs some investment before they're ready to move. So we can kind of lay out a timeline. I might have mentioned this in January, but really we will be, start those that are ready and will go, and we'll get resourced to get moving. Those that aren't will get investments to build the infrastructure they need to get moving. And so we might have providers starting whatever that means, at different phases based on their readiness. This is part of, we talked earlier about the addendum agreement and expectations for providers in these first 6 months. One of those to derive payment will be to fill this out to do, and you'll be getting more information about what is required to do that so that we can assess our provider network. identifying the strategies for capacity building, those domain one things. So I told you point B just started on Monday. They're going to help us work through the HIT stuff. We'll work through our work groups and transformation committee around some of the more workforce issues as we operationalize the different activities. Selecting and validating the target population and evidence-based approaches, we are very far along in that. The design teams did an amazing amount of work in 2017, so it's just really refining and nuancing, especially around the target population, because we'll want to, we're trying to kind of figure out that balance between numbers and equity, and is there a shared population of folks in there? You saw the slides that Marguerite presented. People with chronic behavioral health disorders, that are going to the ED a lot and so forth, that we might start with and then bring out other populations from there. So more to come on that. And then it's the relationship with the providers. So it's getting you guys registered, finalizing those addendums, which is kind of a contractual relationship, and get money out. The final implementation plan, which is due October 1st, basically says, takes into consideration all of these things and says, here's how we're going to do it. Here's our milestones and our timeline of how we're going to get it going, and things will launch in 2019. And then you guys saw this before, just gives you the big picture. So all planning and those things I just described happen in 2018. Implementation is in 2019, and then the scale and sustain. So that's kind of the ringing out. Not everybody's going to start at the same time, but we'll bring in additional providers as they're ready. And just another version of the timeline here. So we're working, the current state assessment is likely, we're targeting, early to mid-March for that to come out. We'll get the data collected. The project work groups are starting, and they'll work through June to get that done. Okay, so I'm going to stop there. I'm going to turn it over to Gina, who is with HealthierHere and is our director of programs. Next part.
Thank you, Susan. So this is the interactive part of the afternoon, which is great because you guys are probably getting a little tired of sitting and listening. So this is where we need your input, and we actually have some thoughts on how the folks participating, the 35 odd folks participating in the webinar can participate along. Essentially for the online folks, we have a moderator who is monitoring a chat. And she will be essentially kind of guiding you through the questions, and we'll be able to capture through the chat function the input that folks online are contributing. And then for folks in the room, we are going to be capturing on these flip charts. We're going to divide folks up into groups and have us discuss some of these questions. So for the 25 some people in the room, we've got 4 categories of provider type: hospital health system, behavioral health, community health center, and community-based organization. I just want to get a sense from a raising of hands, who would be sitting in the hospital health system seat? Okay. We will, in just a moment, we'll have you guys convene over at the corner by this front door. Who would consider themselves a behavioral health provider? Okay. Why don't we have you folks convene in the back corner underneath the exit sign over here? And then community health center. We have 1 community health center. We definitely would love to get that perspective as well. Why don't we have you back at the other back corner here? And then community-based organizations. Adam, okay, great. Maybe we could put, yes, we can put our community health centers and our community-based organizations together in the back corner. So we're going to have a HealthierHere staff member moderate the conversation, and we want you all to decide who will be the person to report out and who will be the scribe. So we have the flip charts, the markers for each, and then we have some discussion questions for you, which I'll explain in just a moment. But what we want you to do is for you to capture your key points on the flip charts and then be ready to report out. And I think depending, we're just gonna kind of gauge how the conversation goes. We have 2 questions. We may only get through 1. We're not trying to pressure things there. People on the webinar probably will move through the questions more quickly, but we're gonna try to move the groups through the questions at the same pace. So we'll be checking in to see how folks are, maybe 10, 15 minutes per question. We'll just see how things go, and then set some time aside for reporting out. And we're really interested, let me just explain, part of the reason for dividing you all into provider type groups is you're gonna have conversations and to actually report out and share kind of across different provider types what your perspectives are on these questions, I think is part of the learning that we're trying to do, and hopefully will be informative to you all in the room as well. So getting back to the project portfolio that Susan introduced, we had our the 4 project areas, but as she had referred to, the care coordination piece is sort of the one of the undergirders of our portfolio approach. So when we think about care coordination, we understand it being foundational to transformation. And we've also heard about the need for shared care planning. So we wanted to focus this first question on shared care planning. So you see the 3 questions under this conversation around care coordination. What I'm gonna have you all do is now go to your respective room to begin your conversations. And maybe what we'll do is we'll have, why don't we have, let's see, Kirsten, do you want to be in the back corner with our CBO, CHC providers, and our behavioral health folks who are back there? Tavish, do you want to join in with that group there? And then Susan, do you want to be up here with the hospital health system folks? Okay, great. And then I'll just kind of circulate around and monitor things. How does that sound? Okay, great. Okay, so now I'm speaking to the people on the webinar, not to the people in the room. You all have a chat function. There is a GoToWebinar menu someplace on your screen. And if you have not been using it, if you can pull that open, you can participate in the online chat that is going on now regarding care coordination.
Folks in the room, you can rip those off and put it on the window if you want it easier.
And also some are moving on the opposite side, where we need to hear experience for changes to have an existing care care provider. And so then we don't know what factor are being on the patient part for us
So you're to make sure that I don't feel so this is.
To chat.
We work, on the police side, we work pretty closely with Valley, number of patients, same, right, we're taking care of, well together.
I don't know.
And we're versus having chemical nutrition, being able to connect the computer and really good stuff. So, here we go. Two reasons. One, I actually think that the linchpin is the project because whether you're home or not, whether that's where we can find people and try to make this impact. I led 45 we're exploring to information children's one very small actually so that's a letter that comes to myself. So basically, that we help yeah, we don't want to know that we're generally ideally, it would all have to be It's now possibly a small scale.
Oh, that's. Okay, yeah. I think to some extent that's the idea. Many people. That would be wonderful. When they show the they're trying. Let's get another. Yeah, we said that you get access to.
It's not obvious.
To build out. There's not a direct way. So it's not a your point, wasn't here. I think it's also well, and then everybody else. We're on that thing right now. I would ask. Yeah, well, this is another way of hearing software that we, and we're trying to build now like a single, almost a dashboard. So they're not numbers. Sorry, I didn't know about this. Data from. No, I assume there were since last year. Similar. Trying to streamline it, we can still. I think that's right. That's and they automatically put that and then they the things and other functions are functions. They're interacting with us. And so we're trying, it's like doing some engagement, right, like we're doing like the student policy first, but we're looking together on our chat. But again, it's like. Any questions? Right.
Most of it is, a lot of it is hard work.
Yeah, and I realized I got people.
The other thing you mentioned was like they can see.
Next, what's the thing?
Oh, that's why. One of the reasons. I love a holiday, President's Day.
Yeah.
Well, even if it was having a care plan, you can get access to it. Yeah.
Okay, folks, we are gonna return to the larger group so we can do some recording out. And for those who are interested, since I think we really stayed with that care coordination, shared care planning question, to share the second question related to health care and social determinants. I'm just sharing this with you. I'm not going to ask you to discuss it, but this is for the next provider summit where we can go into further conversation about this question, which is very important to the ACH around bridging community and social services with health systems and how to go about doing that. So we won't talk about it now, but something to be thinking about. That's what we think a lot about within the ACH. Into the larger group, or if you want to stay where you're at, actually maybe that would be a lot easier. If I could get someone with a mic who could bring that around to the groups. Okay, so who wants to start? Is that raise your hand. I'm gonna, let's see. The hospitals sector folks, let's have you get started, and Kelsey's bringing a mic over to you so that people who are on the webinar can hear the conversation that you guys have been having.
I knew they would act.
Okay, so I'll be describing for a moment here. So first we talk about shared care planning, what does it look like, and what are we doing now? And there was a lot of discussion about, this is the hospital sector, speaking about discharges and how can we be bidirectional when we are referring out from a hospital to a community provider or a home health provider or even the fire department. That it's the bidirectional piece that's very difficult. Even when we have community health workers, they generally call, but we don't have a good closed loop system to know if in fact somebody made it to the referral. So that's the challenge we have. Can't see the care plan if the PCP is outside of the system. And having that link is going to be very, very important. Often good information and work is happening, but it's done in tandem. And linking to social services is very difficult. So one of the comments was, since many people may end up in a hospital, if they have a serious issue, how can we build out a better communication tool to community providers? And started having a good discussion about what some tools we might be able to build on are. And we started getting into what shared care planning might be. And we talked about whether we could look at building out a system called EDIE and pre-manage that allow us to have care plans that could be seen both in the community and with providers, and developing some linkages with FQHCs and BHO providers so that there be some two-way communication back and forth. We spent a lot of time talking about that and how to leverage some of the resources in some of our existing systems like Epic to be able to see visits in Epic everywhere linked to that care. And we were ending up talking about maybe we could test something like that as we looked at a bidirectional portal that people had access to improve care planning.
Great, thank you, Elise. So I'm actually going to put the folks in the back corner on the spot. I didn't preempt you, but curious, any thoughts you all have hearing about from our hospital provider folks, what they shared? Is that any reflection? How does this make sense regarding your, you guys are the community health clinics, right? Is that right? No, behavioral health, sorry. Behavioral health folks, how does that sound to you, what you heard from the hospital folks? Microphone to someone who wants to make a comment?
Oh, hi. Oh, yeah. Does anybody else here from behavioral health non-dogs or Fairfax, do you want to say anything about there? I want point to give us some talking points here, but I want to give them the opportunity.
So I'm with Fairfax to give you perspective. Behavioral health hospital, and it's very similar what you guys are discussing, except we're not on a EHR, kind of what we're discussing.
Do you want to come up here and speak?
No, she doesn't.
It sounds very familiar, but also I guess kind of our group, my experience at a behavioral health hospital is a bit different than kind of what the realm they're in. But a lot of using EDI, pre-manage those systems is kind of like care coordination. I guess I'm not sure what else you're wanting to hear, but very similar, absolutely, and I would second and all of those things that you mentioned, and those are all wish lists on ours as well. So, great, thanks. So, why don't we have the behavioral health folks report out on how they responded to this question of care coordination, and I'm going to move next to, I think, either Kirsten or Marguerite is going to be representing the CBO. I'll have you reflect on what you hear from behavioral health.
Hey, it's Amina. I've been voluntold to report out for behavioral health and happy to do it. So, similar conversation in some ways you just heard. We really talked about the importance of trying to anchor that shared care plan in primary care from the outset as an opportunity for us to sort of integrate other other miscellaneous care plans that exist through other organizations, whether they're behavioral health organizations or CBOs, or managed care, but using that primary care as the basis and building off of that. And so if we're looking for an infrastructure build or support, it would be anchored in primary care. But we also talked about the importance of understanding where the patient is coming from and where they are going to. So we did some discussion around, the facilitation of discharge planning and sharing that throughout our community and kind of the stakeholders around the work as well. We did engage in the conversation around the dearth of electronic health record systems in behavioral health, and that's a clear area of opportunity for ACHs to make infrastructure investments moving forward. And I know that all of the ACHs are thinking about that. We had the opportunity, because we had representatives from the SCORE jail, to talk more specifically about jail transitions and data sharing among different organizations involved in moving patients through, for inmates out to behavioral health and other primary care needs, and what kind of, wish list information we might need to do that more effectively. And we talked about having better demographic information, treat to target information from primary care, and the patient's stated goals from that primary care record that would have helped behavioral health providers tremendously in better serving these. We also talked about the need to have kind of additional support systems for inmates moving from a jail setting to behavioral health, such as I think the term was fast lane, kind of a fast lane need to ensure access to care quickly, timely, and also the importance of very warm handoffs to ensure that people don't fall through the cracks or bolt and then, just cause so many more resources to be poured into trying to track them down and get them cared for.
Great, thank you so much. That was a great report. Do the CBO, CHC provider types want to comment on what they heard? Okay. Okay, so would you like to come up here then and report to us about your discussion within your group who has
Our group of one.
folks who've dispersed since, but you can represent what the conversation was.
Okay, we have, and that, now that's really far away. So, that's really far away. Thank you. So when we were talking about what the need was, one was the thinking about why do we need shared care planning. Some of that is because the needs of the community health center clients are in fact many and complex, and talking about even the need of looking at when having a linkage with behavioral health providers. It's not just one behavioral health provider, but in fact a multitude of different kinds of providers who deal with different kinds of populations as well as conditions. And so really part of what the immediate need of the community health center was in fact to have sort of the backdoor links to be able to quickly be able to provide resources or to have those types of needs addressed, whether it's housing, food, or different kinds of behavioral health conditions. One model that worked really well in that is a partnership that this particular community health center has with AmeriGroup, where because the needs are so many and so complex, that there's actually a system of coordination that the community health center can refer that individual to, or individuals, and AmeriGroup is helping them in that case handle those requests and those referrals. In terms of the shared care plans, the current experience is around having, because they are on NextGen, and knowing that they have a connection, for instance, with Swedish, who is on Epic, and having providers have the knowledge of having, being able to know how to use both NextGen and Epic. But it does mean that for the provider, they have to look at multiple EHRs. And so just thinking through that. The one suggestion was the Project Access Northwest model works really well for the community health centers in getting patients to additional specialty care or other resources. The one other point is around thinking through use agreements. That's what organizations would have to do in order to be able to access other somebody else's electronic health records, and what might that look like when we come up with a shared care plan arrangement.
Thank you, everyone. This is wonderful. I think it's been a good conversation, a good discussion. I think this series of discussions is really just beginning. And so what I wanted to do is move us to closure. Considering it is 6 o'clock on a Thursday before a holiday weekend, and we have a Survey Monkey for people on the webinar. You can click on that link and respond with the survey. For folks in the room, you will be emailed this information tomorrow, as well as the PowerPoint presentation and any follow-ups. For those who have not signed in at the back table, if we don't already have your information, if you didn't receive the direct email from us inviting you to this provider summit, then we don't have you in our system. So please sign at the back table. And I just wanted to let folks know that the next Partnering Organization Summit is on the Ides of March. Wednesday, March 14th, we will have a webinar and an in-person, just like today, back at this location from 4 to 6 p.m. And I just wanted to thank all of you for your active participation and collaboration, for your interest in this topic and what we are attempting to do in King County to transform the system. So thank you so much for being here.